Okay, to continue, we're going to talk about looking at the heart and examining the heart. One of the major things, as you know, is auscultating the heart, listening to the heart sounds. And there's two sounds. There's lub and dub. And what this is the valves closing. When you open a door, does it make a noise? No. When muscle contracts, does it make a noise? No. When you slam a door, is there a noise? Yes. The cusps of the valves slamming together is what makes the noise. So the first sound, the lub, is the sound as the atrioventricular valves close. Now, this signifies the beginning of systole. Systole is the contraction of the heart. When the action potentials have started and the heart is actually contracting, the ventricular systole is when the ventricles are contracting, and that's when the pumping action happens. Diastole is when the heart is relaxing and filling. So as systole starts, the pressure in the ventricle goes up, and in the left ventricle it causes the aortic or the mitral valve to close, and in the right ventricle it causes the tricuspid valve to close. And they close pretty much simultaneously, so they get a sound. It's a fast sound. Lub. The ventricles contract, the pressure goes up, the valves of the great organs, the semilunar valves, open, or the great vessels rather, the semilunar valves open, blood rushes through into the aorta, into the pulmonary trunk, and then when the ventricles start to relax and the pressure in the ventricle drops, as soon as it drops below the pressure that's in the aorta or the pressure in the pulmonary trunk, then those semilunar valves close. But what happens is the aortic pressure is higher than the pulmonary pressure, so it closes first. So they're not simultaneous. So you get sound. You get a sound. And those are the two valves closing, the semilunar valves closing. So you get sounds. And that will come across on the stethoscope as lub, dub. Any other sounds than that are called heart murmurs, and they indicate usually some sort of valve problem because it's the valves actually making the sound. Okay, when you auscultate, you're going to learn how to do it, but you auscultate in numerous places on the chest so that you can hear the predominance of each valve, so that you're listening for murmurs in each of the valves. So you're down here to listen to the tricuspid, you're at the apex to listen to the mitral, etc. You will learn this in assessments. So I've already said that systole is contraction and diastole is relaxation. Be very careful. You probably have already learned that the systolic blood pressure is the higher number of blood pressure and diastolic is the lower number of blood pressure. These things are the blood pressure at the time of systole and at the time of diastole. So at the time that the heart is contracting, the blood pressure is the highest, and at the time of diastole, the blood pressure is the lowest. That's why it's systolic and diastolic blood pressure. In those cases, systolic and diastolic are adjectives. Systole and diastole are times in the heart. It's when the heart is contracting and when the heart is relaxing. be very careful in a test. If you're asked to define systole, don't say it's the highest number in blood pressure, because that's a systolic blood pressure. Okay, so what's going to happen? It's because this is a cycle, we can start anywhere. So we're going to start at mid to late diastole. This is the time that the ventricles are filling. The mitral valve and the tricuspid valve are open because there's no pressure to push them closed. The blood just flows passively into the ventricles. 80% of the blood happened at this time. So blood is flowing from the vena cava into the right atrium, through the open tricuspid valve, into the ventricle. It just passively fills. Then the SA node fires, which causes systole in the atrium, which squeezes the atrium, which squirts another 20% of blood into the ventricle through the open AV valve. And then this becomes the most blood that's in the heart. This is the end diastolic volume. The volume at the end of diastole is the most blood that there will be in the heart in that cycle, in that beat. So ventricular diastole ends and becomes ventricular systole. We get the action potentials and we start contractions of the myocardium of the ventricle. So the atrium now relaxes and the ventricles begin to contract. The pressure in the ventricle goes up, which then pushes the AV valve closed, and you get love. So the left ventricle causes the mitral valve to close. The right ventricle causes the tricuspid valve to close. But the pressure isn't high enough to overcome the pressure on the semilunar valves. So for a very brief period, the pressure is rising, the AV valves have closed, but the SL valves, the semilunar valves, have not opened. And we call this the isovolumetric contraction phase. So all the valves are closed. Isovolumetric, the same volume. So the pressure is increasing without the volume changing. Then all of a sudden the semilunar valves open because the pressure in the ventricle exceeds the pressure in the pulmonary trunk and the aorta. As soon as that pressure, the back pressure on the semilunar valves, is less than the pressure in the ventricle, the valves open and blood is ejected from the ventricle into the big arteries. And it squeezes out as long as there's pressure. At the end of systole, then what happens is there's not all the blood has left the ventricle. So the amount of blood remaining in that ventricle is called the end systolic volume. It's the least amount of blood that's going to be in the ventricle in that heartbeat. So if end diastolic is the end filling volume, end systolic is the end emptying volume. And the amount that left, which is the stroke volume, is the difference between the two. How much you brought in, how much you left in. So how much you brought in minus how much is still there is what left, the stroke volume. As diastole starts in the ventricle, in the walls of the ventricle, the pressure starts to decrease. The pressure decreasing causes the semilunar valves to close because the pressure in the aorta and the pulmonary trunk are higher than the pressure in the ventricles. Those valves close, one and then the other, so that you end up with the dub sounds. As that valve closes, now it's a closed chamber because the pressure is still too high to allow the atrioventricular valves, the mitral and the tricuspid valve, to open yet. We have this time of isovolumetric relaxation. There's no backflow of blood, there's no flow, and so even though the lumen's getting bigger, the volume of blood in the ventricle hasn't changed, and therefore the pressure drops. So if we were to follow this, the amount of blood as filling goes in here, so this is the volume in the ventricle. Blood passively flows in here, and this is where the atrium undergoes systole, and more blood goes in, another 20%, to the maximum amount of blood right here, the end diastolic volume. Then we have from here the isovolumetric contraction. So right here is when systole starts. All the pink is in systole. Then the valve opens, the semilunar valve opens, and all the blood leaves the ventricle. This is the stroke volume. We get to here at the end systolic volume, because systole is here. Diastole starts here. The semilunar valve closes. Dub. Isovolumetric relaxation. And then right here is when the atrioventricular valve, the mitral valve, if it's the left, opens, and we have the passive filling coming to here. Atrial systole gives a little bit more to get to the end diastolic volume, and we start again. So AV valves are open in the blue, they're closed in the pink. Aortic valves are closed in the blue, open in the center part, the white part, and then this, both are closed in the isovolumetric parts. At the same time, if we look at pressure, this is the pressure in the atrium. So if this is the left atrium, pressure is low, passively filled. We get a little bit increase in pressure for atrial systole. There's a little bump, and then the pressure goes down and passively fills from the pulmonary veins, etc. So pressure stays relatively low. The pressure in the ventricle at the same time goes up a little bit because of the extra blood being pushed into it by atrial systole. The valve, the AV valve closes, lub, this first sound. Systole starts, pressure goes up very rapidly, going up until it reaches the pressure that will overcome the semilunar valve. The semilunar valve opens. This is the ejection phase. The amount of blood gets pushed out and it's still contracting. And now there's less blood, so there's less pressure, so the pressure starts to drop. Diastole starts here, and the ventricle walls start relaxing. Pressure drops to below the aorta, so the aortic semilunar valve closes, dub. Pressure steeply drops off during the isovolumetric relaxation. Then the mitral valve opens again. and there's no pressure until atrial systole. This is passive filling, so that's the pressure. This is the pressure in the aorta. Pressure in the aorta drops to just below 80, then goes up to 120 because of the ejection phase. When the valve closes, there's a little backslosh, which causes a little jump in pressure again. And then as the blood moves out of the aorta and into the rest of the arteries and the capillaries, pressure drops and the whole thing cycles again. If we look at the ECG and match that up, P is depolarization of atrium, and it just is ahead of atrial systole. QRS is the depolarization of the ventricles and the repolarization of the atrium, which causes ventricular systole. Then there's the ST interval, and then T is the repolarization of the ventricles, which then causes diastole to happen. And then you have the quiescent period before the next P. The length of this period is what's variable in different heart rates. If we look at where the blood is, you can follow along in the same bit. So this is atrial filling, this is mid diastole, this is late diastole. Then we have, so mid diastole is passive, late diastole is the atrium contracts and pushes the extra blood in here. The AV valve closed, isovolumetric. The semilunar valve opens, ejection, isovolumetric relaxation, pressure dropping, AV valve opens, and you get ventricular filling. So we really don't care how much blood comes out of the heart per beat, so much as we care how much blood is pumped by each ventricle in a minute, because that's what the body needs. It needs blood delivered as required. So we call this amount of blood per minute in each ventricle the cardiac output. And really, it's the stroke volume, the amount per beat, the amount of blood per beat, milliliters per beat, times the heart rate, which is beats per minute, which then gives you volume per minute. So HR times SV equals CO. Normally, cardiac output at rest, in the average person, it's about 75 beats a minute. The stroke volume is about 70 milliliters per beat. You're going to get about 5 to 5.25 liters per minute of blood pumped by the ventricles, which is interesting because there's only 5.25 liters of blood in the circulatory system. So that means every drop of blood in your body passes through your heart every minute. The maximal cardiac output is about 4 to 5 times the resting in non-athletic, right? And that's because you can't get the heart rate up past about 200 and something because of the long refractory period. The slower the heart rate, so if you can get your stroke volume up because you're in shape and the heart, you've been taking cardio classes and you get your stroke volume up to 90 milliliters per beat, then you can slow the heart down to 50 beats. I apologize. You can slow the heart down to about 50 beats per minute, and you still have the same resting cardiac output of about 5 plus liters per minute. But then that means that you can speed up the heart rate and really increase your cardiac output. So that's what being in shape is. And we call this the difference between the resting heart rate and the maximal heart rate, the cardiac reserve. And the better shape you're in, the better your cardiac reserve. So the stroke volume matters. So we just said that cardiac output is what we need, what we're shooting for. So we have stroke volume and heart rate to manipulate. So we'll manipulate the stroke volume first. The stroke volume is the end diastolic volume minus the end systolic volume. So the most blood that can be in the heart in a beat minus what's left over at the end of systole, at the end of the heartbeat. So we end up with the stroke volume, the amount that leaves. So there are three factors that can affect this. There is the preload, the contractility, and the afterload. So preload is how much blood are you returning to the heart. So more preload increases the end diastolic volume. So there's more blood to pump, and therefore you can have a higher stroke volume. Contractility is how hard you squeeze the heart, and what that does is it lowers the end systolic volume. So there's less blood left in the heart. You've squeezed more of it out. And the afterload is really the pressure that's in the aorta or the pulmonary trunk that is forming a resistance against pushing the blood out of the heart. And so an increased afterload increases the end systolic volume, so it decreases the stroke volume. Think of a bicycle pump when you're pumping up a tire. If you want to pump up a tire, you pull up on the handle and you load lots of air into the pump. Then you push hard and the handle all the way down. And then as you pump the tire up and there's more air in the tire, there's more resistance, and you have to push harder to overcome that resistance. That's preload, contractility, and afterload. So preload is really the major determinant of this. It is how much the stretching from filling the heart causes the myofibrils to overlap to get a good length tension relationship. And how much time you have for venous return. So if you have a lot of time, there's more return, more blood comes, which then makes the optimal overlap between the thin and thick filaments, and you can have a better contraction force. So both of these things, so the preload means there's more blood there to pump, and you're better at pumping because the heart is optimally set up for contraction. So Frank Starling's law of the heart says preload is the most important factor. Contractility is anything other than the muscle stretch that is going to cause the heart muscle to contract. So if there's an increased amount of calcium, you'll have more cross-bridging. And so that could be sympathetic stimulation. So sympathetic stimulation not only increases the amount of sodium that comes in, but it also increases the amount of calcium. So the heart beats faster and stronger. Various hormones will increase it. So epinephrine, glucagon, that kind of thing. Negative that decrease contractility, but things like acidosis, calcium channel blockers, so that would be various drugs. Too much potassium will do it, because the sodium potassium pump, if there's too much potassium, then you don't get enough sodium. It's harder to get to that balance, and the heart will actually not contract as well. Afterload is the resistance against the blood leaving the heart. So it will increase the end systolic volume and reduce the stroke volume. So that means that if you are hypertensive, if you have high blood pressure, then your heart has to work harder. It has to contract. It needs more contractility to overcome the afterload. It's one of the reasons that hypertension is the silent killer. The heart has to work that much harder. You can get an enlarged heart because the heart's a muscle and it will hypertrophy if there's too much afterload for too long. So we can regulate the stroke volume through this. We can regulate the heart rate through different factors that increase the heart rate or decrease the heart rate. So there's a nervous system regulation. So sympathetics increase the heart rate. So norepinephrine causes the pacemakers to fire more rapidly, increase contractility and heart rate. So sympathetics increase the rate and the contractility. So it increases the rate and the stroke volume, so dramatically increases cardiac output. Parasympathetics oppose the sympathetics. You hyperpolarize the pacemaker cells and you end up decreasing the heart rate, but it has no effect on contractility. So sympathetics don't affect contractility, but parasympathetics, by slowing down the heart, cause more filling, raises the end diastolic volume, and therefore you don't need more contractility, according to Frank Starling's law. The Bainbridge effect is a sympathetic reflex that's caused by the stretch of the walls of the atrium, and it stimulates the stretch receptors, activating the sympathetics. And so what ends up happening is you don't want to stress the heart by overfilling it. You can, and so the Bainbridge reflex prevents that. So you can increase their venous return using muscle and respiratory pumps. So as smooth muscle or as skeletal muscle contracts, it squeezes on the veins, which pushes blood and with the valves back towards the heart. Taking a deep breath decreases the pressure in your thorax, which actually sucks blood back to your heart. So it increases the venous return. Having a low heart rate increases venous return because there's more time. Increased venous return gives you more end diastolic volume, which then increases the stroke volume, which then increases the cardiac output. If you have sympathetics, so epinephrine, thyroxine, you increase contractility, which decreases the end systolic volume, which increases the stroke volume. So you decrease the end systolic, how much is left? You increase the stroke volume, which increases cardiac output. Sympathetic activity increases contractility and increases heart rate, which increases cardiac output by increasing stroke volume and heart rate. Parasympathetics actually decrease heart rate, which will decrease cardiac output. So we regulate with hormones, we regulate with ion concentrations, right? Other factors would be age, as all of this works less well as we get older. Gender makes a big difference, because some of the hormones, like testosterone, actually enhance most of this. So exercise matters. The more you exercise, the more your heart rate goes up. And body temperature. So as we get colder, we have to increase our heart rate to try and pump blood around and stay warm. Um, and that's it for cardiac.